Thank you for coming on to the show. Let's start with the basics. What is GLP-1? Where is it produced and how does it work in our body?
Yeah, thanks for having me, Aaron. So you put me under pressure already because actually this is a topic that endocrinologists have worked on for decades, really.
Mhm.
And as a psychiatrist, that makes it a bit difficult, but I'll try my best. Okay. So GLP-1 is an acronym and it stands for glucagon-like peptide. Therefore, you can guess it is a peptide, basically a very simple protein made of a small number of amino acids. It's actually a very simple structure. And it is produced in various parts in our body, but mainly it is produced in our bowels and in response to food. And the reason for that is that then it plays a role in response to food for the secretion of another hormone that I think most people would know about, which is insulin. It's obviously very much involved in diabetes. Hence the reason why, as I was saying at the very beginning, endocrinologists are the people who are basically pioneered the use of this medication.
So you are a psychiatrist. You have written a brilliant review on the effects or potential effects of utilizing GLP-1 agonists in cognitive disorders, mood disorders, etc. Now, obviously, if someone we know about Ozempic playing a role in weight loss, obviously that's what plays a big role in social media in the modern world. If someone loses a significant amount of weight, one could argue that their mental health is going to improve. But what's even more fascinating and what your review highlights is the idea that GLP-1 receptor agonists might also directly act on the brain. And so reward pathways, mood regulation, cognition. We're going to delve into this in a bit more detail, but could you provide sort of an overview as to what kinds of cognitive and mental health conditions are researchers currently exploring GLP-1 receptor agonists?
Yeah, I think you make several excellent points there, actually, Aaron. And the first question that probably is in everyone's mind is, I've been talking about bowels mainly so far, and I've been talking about insulin. Why
Mm-hmm.
does have anything to do with psychiatry? And one of the reasons for that is that actually we do know that this GLP-1, this peptide, is also, so not the medication, our endogenous peptide, is also produced in certain brain areas. And in certain brain areas, there are actually receptors for these endogenous peptides. And the idea is that, as you're saying, obviously, apart from being used for diabetes, one of the reasons why everyone knows about these medications today is because of their quite striking, actually, effect in obesity. And the main mechanism that was initially postulated for that was that it delays gastric emptying. So our stomach emptying becomes a bit slower, makes you feel full a bit earlier, and therefore you feel like eating less. But then they realized this is not only happening in what we maybe a bit arrogantly with psychiatrists call the periphery. It also happens centrally in the brain. And it could be that these this peptide and its receptor are actually involved in appetite regulation at a central level. This is, as you will see, many things that I will say, unfortunately, we can't be too sure because lots of the evidence comes from animal studies,
Mm-hmm. Mm-hmm.
which, as we all know, is, I don't know whether you will agree, but it's quite difficult to
Yep.
translate
Yep.
in humans. But maybe in this specific circumstance, I would say I would dare a little bit of more confidence in saying that actually appetite mechanisms, they are likely to be quite similar across species. So there is a good chance that what we are seeing in animal models, in the brain of the animal models regulating appetite, might apply to humans as well. When it comes to the cognitive and mental health mechanisms that you were mentioning, the situation you can probably guess it becomes far more complicated, right? It's very difficult to compare cognitive processes in mice or in rats and in humans, and likewise for behavior. So we don't exactly know what the mechanism what the mechanisms are. And actually, my research group is one that is actively investigating this area, and we're hoping to have our first paper out soon.
Mhm.
But the landscape, I don't want to sound overexcited, but looks quite promising.
Mhm.
It looks, I think at the moment, the most promising avenues for potential applications in psychiatry, as you were asking me, would be cognitive disorders. So we are talking about basically dementias, especially Alzheimer dementia,
Mhm.
addiction of
Mhm.
probably different kinds. So whether we are thinking about alcohol addictions or other recreational drugs, there might be a space in other maybe more classic psychiatric disorders, schizophrenia, depression, or mood disorders in general. But that's a little bit more unknown.
So do you think, again, that the mechanism, we're still sort of early days with regards to understanding it fully, but do you think it has this sort of pleiotropic effect? So it can affect multiple pathways in the brain or multiple areas in the brain and have this sort of holistic beneficial sort of effect on brain health, which is why it could be applied to so many sort of cognitive disorders.
Yeah, that's a double-edged sword, isn't it?
Mhm.
In the sense that when we say pleiotropic, oftentimes we mean we actually have no idea, right? So it definitely that there is a good chance that it can affect several pathways, and each and every one of these pathways might be involved in different mental disorders or cognitive disorders. Obviously, the difficulty is that also for psychiatric disorders in the first place, we don't know exactly what the pathways that are involved are.
Yeah.
In fact, one of the take-home messages that I would like to leave today is that these might actually differ from patient to patient, even if they're presenting quite similarly, or they're receiving the same diagnosis, whether it is depression or Alzheimer and so on. So I think it is quite complicated to say whether the pleiotropic effects are necessarily an advantage. Some of the pleiotropic effects might actually present a disadvantage, right? If this medication did something that actually is not helpful for that specific mental disorder, but it might be helpful for another mental disorder. So obviously, as we try and understand a bit more about this, maybe we will be able to develop more targeted interventions, looking at the mechanism. But at the moment, I'd say we are quite far from there.
Yeah, I mean, I've spoken to other researchers at UCL or KCL who work on sort of depression and anxiety, and I think one of the complexities with depression, specifically with mental health conditions, is that it's really hard to sort of delineate what the actual sort of pathogenic mechanism is compared to, let's say, where you can target specific genetic mutation, for instance, or any sort of monogenic diseases such as rare diseases. And so do you think maybe we're jumping ahead looking at the application of GLP-1 agonists when we should sort of maybe have a better understanding of the mechanism of, let's say, mental health disorders, or can we do that sort of concurrently together, if that makes sense?
You're asking me a very difficult question. I'm going to give you satisfaction and give you a slightly controversial answer in the sense that, I think we're probably jumping ahead.
Mhm.
But then again, we have no alternative, I think, because we are so far, unfortunately, from fully understanding the pathogenetic and physiopathological pathways behind psychiatric disorders. If we didn't try to jump ahead even there, then we would not be able to come up with new treatments probably for a very long time. So I think your suggestion is probably a good one. Try to do both things at the same time. I wish we could see actually a bit more of that when we do studies, randomized controlled trials, for example, in which we are trialing a new medication for a psychiatric condition. First of all, we should be deeply aware that one of the reasons why we might not see it working is because we are giving it indiscriminately to a number of people who we're all calling as depressed, but then perhaps they don't all have the same kind of depression. And secondly, I think it's very useful if we try and include some, I'm going to use a bit of jargon, some mechanistic measures, some biomarkers, basically, that
Yeah.
perhaps could tell us a little bit more about the mechanism of the disorder itself. So hopefully with an idea of one thing informing the other.
Yeah, that's funny you mentioned that. I was actually in a sauna last week with an epidemiologist, and we were talking about how maybe there should be better sort of biomarkers implicated in clinical trials that have a better understanding of the therapeutic effect of a certain drug. Do you think, especially with depression, we should be looking at sort of patient subsets? So, for instance, you talked about inflammation and the effects of GLP-1 agonists and its effects on inflammation, on insulin resistance and whatnot. Do you think subsetting patients and going down that route could be beneficial in the future?
I see you did your homework, so that's a very good suggestion. I definitely think that. I think, and it might be proved wrong, but I'll be very happy to hear whether you think the same. But maybe it's better to be proved wrong, and then we can move on to the next hypothesis, rather than just having to rely on these very large trials, including everyone, and then the trial brings to disappointing results just because we have not been brave enough, I dare say, to say, actually, let's try and focus on this very specific subset of people and see what happens there. We do have biomarkers. They are not ideal unless we take a little bit of courage and test them. I don't think the field is gonna move forward.
So do you think that's why in your review you mentioned there were sort of discrepancies between rodent, so in vivo studies, and sort of clinical trial data with regards to depression, if I'm correct? It wasn't as clear cut as one might have thought with regards to effects of these GLP-1 agonists.
Yeah, I think that's definitely the case, but it's also the case not just between animal studies, the differences between the animal studies and the human studies, but also within human studies. Is if once again we conceptualize depression as being the same disorder for exactly all the people that we say they have depression, then probably we are making a mistake. And I really like that you mentioned the example of inflammation. I think it's perhaps one of the areas in which there has been the most research for alternative mechanisms that don't have to do with the classic neurotransmitters that I'm sure the audience will have heard about, serotonin or adrenaline.
Yep.
So inflammation is one of the other big research avenues. I would be surprised if we did not identify at some point a very specific subset of people who are either depressed or at the very least they don't respond to our conventional treatment, something that is called treatment-resistant depression or difficult to treat depression, because there is an underlying inflammatory component which is simply not being addressed by the conventional treatment. If we can find a little bit more about that and maybe define the symptoms profile associated to that with a bit more confidence, there is emerging evidence, for example, anhedonia, the lack of ability to experience pleasure, seems to be particularly associated with inflammatory changes. For example, that might qualify a subset of people that might benefit more so than other people with depression from being treated with anti-inflammatories. And you are mentioning anti-inflammatories because I'm sure you want to get to the point that are GLP-1s anti-inflammatories per se.
Yeah. I mean, the reason I'm also interested in it is because I spoke to Dr. Hurd at UCL, and we were talking about the beneficial effects of physical activity and depression. And the majority of the conversation was about how it can modulate, dopaminergic function and serotonin, all those sort of classic keywords associated with depression. But there's new research coming up talking about how physical activity could have an effect on inflammation as well, and how inflammation may have a role to play in depression and also leading to these sort of shifts in neurotransmission. And so that's why I sort of jumped up at inflammation and GLP-1, because it would be very sort of interesting to try and stratify patients. And I think one of the beauties, but also the complexities when it comes to this bridge between neuroscience and psychiatry is really trying to bridge and integrate, let's say, the psychological phenotype with the
Mhm.
neurochemical phenotype, let's say. Is that a good sort of?
Yeah, I agree. Yeah, that's actually the area I kind of work in.
Yeah. Yeah, it's one of hopefully the areas that I move into when I do my postdoc and afterwards. But do you know much about insulin sort of resistance in the brain? We've heard a lot about it in the modern social media, the biohacking sort of world, type 3 diabetes related to Alzheimer's and Parkinson's,
Yeah,
and I I don't know what to think of it. I haven't done enough research on it, but it seems to be quite interesting, especially because you highlighted in your review that GLP-1 agonists may have an effect on insulin, obviously, when it comes to diabetes. But what about insulin within the brain on that sort of system?
I agree. It's a slightly more gray
Hmm.
area, maybe compared to inflammation, for which we know, and neuroplastic changes associated to neurotransmitters, which for which we simply have more experience.
Hmm.
But the brain insulin resistance associated with Alzheimer, I think that there is a more established evidence base. We are not quite there yet to use it as a biomarker, for example, for Alzheimer, but the evidence seems quite promising. For other psychiatric disorders, there has been research done in this regard, definitely for schizophrenia, a bit less so for, as far as I'm aware, for mood disorders like bipolar and depression. That the results, they do seem actually quite interesting, and they might explain a lot. The main issue is, once again, relatively simple to study in animal models,
Hmm.
extremely difficult and a bit expensive actually to study it in humans. So it's not always feasible to study that in human beings. In the study we have done recently, we would have liked to look at that. It's just unfortunately oftentimes not practical. But for GLP-1 specifically, well, I think it's an area where we must go, right? If anything, to try and understand whether there is any involvement or not. And again, it might be a failure, but at least we know that it's a no-go area.
I don't know if I'm going backwards, but so GLP-1 receptors not only located in the intestine, but they're also located in the brain, such as the hypothalamus and other sort of regions. Can all the drugs bypass the blood-brain barrier? And for anyone out there, the blood-brain barrier is basically this sort of protective layer that surrounds the brain, let's say. So can drugs bypass the blood-brain barrier and really act on these receptors?
So I'm gonna give you an answer
Hmm.
that if there is any expert or specialist amongst your listener,
Yep.
that there is a good chance they're gonna jump on me and be like, "This is completely wrong," a bit of a warning shot.
Hmm.
My answer is uh, probably yes, although we don't know quite yet. And the reason why I'm being extremely cautious is because, from personal experience, actually having published in the field, I have found that there is a quite polarized debate
Hmm.
around this topic.
Yep.
I mean, maybe that's always the case, but I don't think for these things we should have polarized debates. We should have a bit of a more nuanced view of that. I don't want to make my answer too long,
Ah,
but
please.
starting from the blood-brain barrier that you were mentioning, what we thought about the blood-brain barrier not too long ago, less than a decade ago, actually, it's been quite completely subverted today. We thought that the brain was an immune privileged um, organ, and that there would be no access of the immune system to the brain apart from the local immune cells. And actually, today we know that that's not the case, and there are lymphatic vessels that are part of the central nervous system. So there's really been a big subversion of what I studied in medical school not too long ago, for example. Um, So first of all, I think a bit of humility in thinking actually we don't know enough is probably quite important in this area. The blood-brain barrier allows for some molecules to pass. Some they can do that passively. In some cases, there are active transporters. That is also quite likely dependent on not only on the charge of the molecule. So lipophilic molecules can pass more easily. Hydrophilic molecules, they struggle to pass. But it will also be related to the dose. So for example, if there is lots of medication, say, waiting to enter, then a little bit of it might indeed enter. Whereas if there is very little dose of medication around, that might struggle to enter, even if it is quite brain penetrant. So you see how nuanced and complicated this whole issue can be. Studying that in humans, once again, is extremely difficult. We do know most of it from animal studies, and the blood-brain barriers of a mouse is likely to be quite different from the blood-brain barrier of a human being. And finally, and this is the area where I feel a bit more confident because it's really an area that has got to do with neuropsychiatry. Each and every patient might actually have a quite different function of their blood-brain barrier, depending on their disorder and at a specific time of their disorder. So just to clarify this concept, we do see evidence, for example, that in Alzheimer disease or in some depressive disorders, the blood-brain barrier might be dysfunctioning, something that sometimes is called as a leaky blood-brain barrier. And that might explain why if you and I take a certain medication, maybe that's not going to penetrate our blood-brain barrier, but maybe somebody with depression, with exactly the same medication and exactly the same dose, might see an uptake of the medication in their brain simply because they have depression. And then what happens once they start getting better from their depression? Does the blood-brain barrier function changes over time? Does it get reestablished? And therefore, the medication is going to penetrate the brain a little bit less and less and less.
Mm-hmm.
You see how complicated it is. So sorry if I repeat myself, but bottom line, polarized debate on this is absolutely unhelpful. We want good answers, but we can only do that by looking at it and not thinking we know the absolute.
Yeah, I completely agree with you. I did some work on the blood-brain barrier due to my master's, and so I was developing these in vitro models. And so I understand the complexity with regards to the blood-brain barrier and how that can differ from patient to patient, but also from disease to disease. And then you've got to take into account the drug in itself, its hydrophilicity, if it's hydrophobic, and all of that's going to play a factor when it comes to bypassing the blood-brain barrier. Do you think it's an important line of research, though, when it comes to repurposing these drugs potentially in the future, where we need to develop very good in vitro models to assess how these drugs can penetrate the blood-brain barrier before we even think about clinical studies? Or is that too sort of focused on the mechanism and the in vitro sort of side of all of this?
Well, I'll answer your question, but then you are the in vitro expert. So if you don't mind, I'll bounce it back to you. I think it's definitely important. We must do that.
Mm-hmm.
If for the very trivial reason that if we didn't do it, then our patients, our funders, they're going to ask for it. They want to see evidence of that. So we must do that. That's going to provide a definitive answer. I'm once again a little bit skeptical for a very simple reason, that we think and conceptualize psychiatric disorders as disorders of the brain. But as I was trying to say earlier, the brain is actually much more interconnected with the rest of our body that maybe we thought not too long ago. So I wouldn't be surprised, for example, if there were medications that could not necessarily manage to penetrate the brain, but they only had an effect in the periphery, for example, in the immune system. But that effect in the periphery might have repercussions in our brain function and therefore mental processes, which are at the end of the day responsible for producing changes in behavior and psychiatric symptoms more. So I think even if we found out these drugs don't necessarily penetrate the blood-brain barrier, that's not the end of the story. We still need to look at the clinical reality of it. If there are patients that actually respond to that, maybe that could still be explained by effects that they have in the periphery, immune system, gut-brain axis. We find out more on a day-to-day basis.
Yep. Yeah, I mean, I was literally going to mention the gut-brain axis because obviously GLP-1 is secreted by L cells, which are located in the intestine, and there's a lot of work going on with regards to the gut-brain axis and how modulation of the gut microbiome can lead to modulation of neurotransmission within the brain. And there's also research linking the oral microbiome to the brain as well. I was talking to a dentist from KCL about that. Your work mentioned, you talked about some work about the effects of GLP-1 agonists improving cognition in Alzheimer's and dementia patients. I'm very big on preventative medicine. I find it very interesting, but I acknowledge the difficulties it has when it comes to sort of designing clinical trials and having a really good understanding of the mechanism. But in the modern world, in the biohacking world, in social media, everything's conflated, obviously. And there's a lot of talk about longevity drugs, how to improve brain health, how to mitigate brain aging as you age, and inflammation and other sort of pathways can contribute to that. Do you think that GLP-1 agonists could play a role in the longevity field? And so we're not just talking about people who aren't in disease populations taking it, but just average normal people taking it from the age of 30 or 40 onwards, just to maintain brain health and prevent aging. One could argue it could be like, potentially the statins of brain health, and statins is a bit controversial, but yeah, what's your take on that?
May I answer your question in two parts?
Yeah, please.
So the first part of it is got to do with what you're saying about Alzheimer and dementias more in general. There has been quite a bit of research done in that area. We simply do not have definitive data yet from clinical trials, but the good news is that a couple of them are actually ongoing. One is actually from the pharmaceutical company that produces semaglutide. That reminds me, I should have said at the very beginning that I have no conflict of interest or financial disclosures to make. I'll do that now. So it's just that this is a very famous study, Evoke and Evoke Plus study.
Yep.
That is looking at this for Alzheimer. Then there is another study conducted by a colleague here in Oxford that is looking at the oral pill of semaglutide and is looking more from a preventative, if you want, perspective, as you were saying, in people who have early signs of Alzheimer because of high levels of amyloid and these biomarkers we normally associate with this kind of dementia. So we don't have an answer to that yet, but evidence, I think, will come up within the next couple of years, really. And that should really be the first step. Then we can move on. This is the second part of my answer to the longevity field. I'm not an expert of the longevity field. I think there are people who have been doing work in this area outside of psychiatry, as far as I'm aware, for a very long time. It is a slightly more controversial field because it does have implications that go really a little bit beyond what we are supposed to be doing clinically. Yeah, we're talking about enhancement almost rather than cure or healing of a disease.
Yep.
So it does beg then a number of moral and philosophical questions and so on. These are powerful medications with significant side effects. The side effects profile is overall benign, but lots of patients might experience side effects such as nausea and belly problems and so on and so forth. And we are still looking at long-term follow-up data on what they could do in terms of harms. One particularly concerning signal that I have noted, for example, is that it seems like a good part of the weight that is lost might actually come from what we call lean muscle mass, and that's you can probably guess is not a good thing.
Mhm.
And without going into too much detail with that, if you think about it, losing lean muscle mass, probably we don't associate that to a healthy aging kind of process, do we?
Yeah.
So maybe they might play a role later on, but not on the current stage, maybe in some modified version, maybe it's some targeted version. But I really don't think we are quite there yet. I'm sorry.
This is a question which is outside of psychiatry, so I don't know if you could give an answer, but do you think we have, from a clinical perspective, jumped into prescribing Ozempic and other weight loss drugs too quickly? Because yes, you could mitigate the loss of lean muscle with resistance training, but we still don't know the long-term effects really of, Ozempic, but lots of people are taking it. And yes, it's changing their lives. And yes, it's, reducing obesity, but we still don't have a full grasp of this drug, I would say. And it has such a widespread use. Me playing devil's advocate, I'm sort of worried about that.
I'm worried too. The counter argument could be that unfortunately we must recognize that obesity is a global pandemic.
Yeah.
It's a real emergency, and we simply don't have good treatments for that. I don't think that these medications are going to be the solution to this massive issue here. If anything, because now wanting to go back into my psychiatrist's shoes, I think that obesity is not simply a disease of having a BMI that is too high and gaining too much weight. I think there are some, in lots of cases, because again, obesity could mean a number of different diseases actually, but in lots of cases, there might be, for example, some deep-rooted psychological issues behind that. And I find it quite striking that psychiatry is rarely, if at all, involved in the assessment and treatment of these patients here. It's a bit counterintuitive if you think that all other eating disorders are actually generally treated by psychiatrists, right? For example, anorexia and so on. So I'm not trying to psychiatricize, I'm making up this word, the treatment of obesity, but I think this kind of input is necessary. Having said that, as I said, obesity is so much of a large problem that we need, if we do get a new intervention that seems to be so effective, it might be worth taking the risk of trialing it, possibly also on a large scale, as long as there is very much clarity with the people who are actually then taking it, that have been prescribed the medication, that these risks are there. And on top of that, we cannot guarantee at the moment that the treatment that they have is going to resolve their higher weight problems forever.
I don't know if you know how long people are on a, let's say, cycle of Ozempic, if they take it indefinitely, if they take it for a number of months, but just thinking out loud, do you think there would be a negative effect on people who would then get off Ozempic or any of these weight loss drugs, where, because Ozempic just doesn't slow gastric emptying, but it can also act on your brain regions and modulate sort of dopaminergic sort of, which could maybe help with regards to, let's say, emotional eating, which can lead to, let's say, obesity in long term. So if someone were to get off Ozempic, are they more likely to have these sort of depressive symptoms because they just can't control that sort of emotional hunger, let's say, for food? And I'm drawing analogies with people who take anabolic steroids. So I had an endocrinologist on a couple of weeks ago, and we talked about how guys who take steroids would make significant gains in the gym. They would look great, they would feel great, but once they get off it, one of the key symptoms is depression, because they lose that muscle. They're not making that sort of same progress. So do you think there are maybe potentially some parallels between the potential depressive onset seen in people who come off anabolic steroids with people who may come off Ozempic?
There might be,
Mhm.
but at the moment we don't know.
Yep, yep.
We are starting to see some evidence, including from randomized controlled trial, that some people seem to regain weight from stopping these medications. Some people do not. And we don't exactly know why that happens and whether that then could lead to more or less depressive symptoms, whether that is actually causative of that, or maybe that's only an epiphenomenon, perhaps, of a underlying depressive psychopathology that had gone unrecognized. We simply don't know. I wouldn't be surprised if both cases were actually true and they just are different for different people. It's interesting you mentioned depression on a few occasions because, well, there is a bit of a story that I'm quite positive you are aware of, that there has been a signal for increased suicidality that initially was
Mhm.
raised with regards to these medications, and then a number of studies came about, and they were finding sometimes no changes in terms of suicidality, sometimes increased suicidality, sometimes paradoxically a protective effect on suicidality. We did a study of that kind, and we found so a null effect, no increase, but no decrease in suicidality. I
Mhm.
tend to believe that, actually, not just because we did that study, but because, well, null findings are oftentimes correct in science rather than more sensational, positive or negative findings. And it's more seriously, it's also corroborated by secondary analysis of randomized controlled trials that looked at this in people with taking the drug for diabetes, and they didn't see a signal either. Now, of course, that could be dramatically different in people who already have a psychiatric disorder and, might be already, because of the psychiatric disorder, more vulnerable to developing suicidal ideation. We simply don't know. We definitely need to go look and look at it. That should not prevent, though, simply on the basis of that should not prevent the use or clinical use or further research into the use of these medications in psychiatric patients, because otherwise, and I'm sorry if I feel so strongly about it,
Mhm.
will be once again a case for stigma against our patients. So I feel
Mhm.
fiercely about it.
So what do you think needs to be done, let's say, in the next 5 years for sort of significant progress later on in a decade or two? Do you think, what needs to be done in the short term to potentially have a better conclusion as to the applications of GLP-1 agonists, not only just in weight loss, but in other sort of disorders affecting the brain?
Well, I can tell you what we are doing,
Mhm.
and then you can tell me if you think it's a good idea. So we are very interested in the mechanism. So we are taking a bit of a step back, and we think we need to understand if there are any cognitive neuropsychological mechanisms at all behind the activity of these medications.
Mhm.
And then from there, we could move on to the next step, which would be, does that mean that we could use this medication in psychiatric disorders too? So we are actively doing research in this area. I think I did mention it earlier. We have recently completed a study of this kind in healthy volunteers, just because we wanted really to see whether we could see any effect at all in a homogeneous sample, all theoretically healthy people. And then the next step would be to go and look for it in clinical populations. Once we have established that with a bit more confidence, and hopefully we will see the results out soon. Or, as you maybe were suggesting earlier, in parallel to that, I think we just simply need to do clinical trials.
Mhm.
There is
Mhm.
lots of talking about these medications. There are reviews being published on them every other day. By all means, guilty as charged myself. But I think at some point we want to, think about not just talking, but doing some research on patients and get data from clinical trials and see if these medications actually can benefit people with depression, with schizophrenia, with Alzheimer, with addictive disorders, and so on.
Has anyone looked at GLP-1 receptor expression in different disorders, comparing between healthy individuals, but also between different diseases? So could, a depressive population, let's say, have a higher GLP-1 expression or lower? Has anyone looked at that sort of expression?
Yeah, I think I know what you're referring to. Yeah, there are a couple of studies, but there isn't much. The sample sizes are very small. This tends to be, I dare say, maybe a slightly less glamorous area of research for some reason. So you don't see an awful lot of investment in that. People want new treatments. They don't want to look at what receptor. So it's a bit complicated. And by the way, I do feel a little bit, well, quite a bit out of my depth, because that's not what I do for a living. So there are probably a number of additional difficulties that I cannot foresee. But yeah, there is a little bit of research in this area. It does seem like the GLP-1 receptor might indeed be involved in depression, particularly as you were mentioning. But again, it's not enough to give any conclusive answer yet.
What specific disorders are you looking at in your lab?
So we, as a lab, we work mainly in the area of depression. You could see it as mood disorders more in general, but really there is a large focus on depression. Our first study, the OXSense study, it was, as I said, in healthy volunteers, because we wanted really to start from a blank slate. And the results of this study are informing the design of our next study, that could be in depression, because we are seeing some interesting data in that regard.
Are you interested in inflammation and looking at sort of cytokine or expression or levels of IL-6 or TNF alpha, and seeing if that could be utilized as a foundational biomarker sort of panel for patient stratification?
Yeah. I think we must do it. We didn't do it, and that's maybe one of my regrets. We didn't do it for the study I was just mentioning. Although I doubt we will have seen anything, because, as I was mentioning, we were studying healthy volunteers. So unlikely to be any inflammatory process that we could see involved, at least not at the levels that we normally measure inflammatory markers, as you were mentioning. The real reason why we didn't do it was a very practical reason, which was we were trying to keep the study quite simple. We were really focusing on cognitive and behavioral measures by biomarkers. But I think the next study, if it is in patients population, we must and we will include inflammatory markers. It's really, in a way, it's a no-brainer. We need to know what is happening in terms of inflammatory markers in the people who are taking this medication for a specific disorder. Whether we are gonna stratify or even select people with high inflammatory markers a priori, I don't know. It's something that we will have to think about. I have done a study before of this kind, where we were only selecting, not with GLP-1s, and we were only recruiting people with high levels of an inflammatory marker. Unfortunately, then the study got shut down because COVID happened, so I could never complete it. But I was a bit scarred from the experience. It's very difficult to organize. So unfortunately, there are practical, but that should be no reason for not trying and doing it this time.
I think over the podcast who I've interviewed, I've sort of really gained an interest in inflammation and infla-aging, which Professor Bryant from Cambridge has used as a term. Do you think inflammation, and this again might be out of your depth, but do you think inflammation may be the crux of it when it comes to psychiatric disorders? And so the reason I say that is because I think in the modern world, with regards to the general public, they still look at depression as just a mood disorder affecting the psychology, or they look at dopamine and serotonin. And those are sort of the key players, let's say, in depression and these sort of mood disorders. But I think we know in the science field that metabolism, the gut-brain axis, inflammation, all of these sort of areas are now becoming a bit more popular and more backed with evidence with regards to depression and all of these disorders. So are we seeing this sort of evolution of our understanding, and do we need to focus more on that, not only with regards to mechanism, but with regards to therapeutics and diagnostics?
Yeah. I'll tell you what, I think I was mentioning earlier that I would be surprised if there wasn't at least a subset of people with depression
Mhm.
whose symptoms or resistance to treatment would not be explained by inflammatory processes. Inflammatory processes or dysfunctional inflammatory processes, to be more precise, are being involved more and more in a number of chronic disorders that either resemble or are closely linked with depression, which is a chronic disorder for lots of people. So I think that's definitely an area that we should be looking at, and we should be looking at it a bit more. I think there are, once again, practical difficulties with doing that. I think maybe people are scared of the idea of then not being able to diagnose depression anymore because somebody does not have raised inflammatory markers and the like. I'm sorry, I think that's really not the way this is gonna go, that this
Mhm.
should go. The diagnosis will still be made clinically, but I think we should be once again brave enough to think that there might be some types of depression which are radically different from other types of depression, and therefore they warrant a different kind of. To try and make it a bit simpler, it could be that there are kinds of depression that are much more inflammatory in nature, and these kind of depressions will be characterized by slightly different symptoms and hopefully a variety of different biomarkers. And then this group of people should be given a certain kind of treatment, which might involve, for example, anti-inflammatory medications. Whereas there are other people with different kinds of depression and with different symptoms profile who might not benefit from anti-inflammatories and indeed might not benefit from other conventional antidepressants, and they would only do well if they're given psychotherapy. I think
Mm.
we need to take a bit of a leap of faith and then do a bit more in this area.
Yeah, I think it's one of the reasons why I'm interested in neuroscience, but I also want to sort of move into neuropsychoendocrinology, let's say, because I think we can't quantify the mind. And I think that's one of the difficulties that we have when it comes to mood disorders. And it requires this sort of interdisciplinary partnership between psychiatrists, neuroscientists, endocrinologists, immunologists to really have a better understanding of what's going on. Final question. We've covered a lot today. So just as a summary, what's your gut take and your gut feeling on the application of GLP-1 agonists such as Ozempic on brain health? Is it promising? And is there a lot of room for improvement in the field?
Aaron, I think both. So I think it's promising for sure. I hope it's promising because we are doing research on it as well. So it would be nice if it did show what we are expecting it to show. And it would be nice if patients could actually benefit from all these research investments that is being done by a lot of researchers throughout the world. I'm a bit skeptical by nature, so I think these medications are unlikely to be a panacea, an all remedy against all diseases. And unfortunately, we do see lots of sensationalism around that in the medias and in the social medias. We should steer away from that and really inform the public a bit more carefully about what we're doing in this area, because otherwise we risk losing it. I would be surprised if these medications ended up playing no role in the treatment of psychiatric disorders, if anything, because these people with psychiatric disorders oftentimes have a lot of metabolic complications, including obesity, that warrant treatment. And I think we really need to move beyond this idea of a separation between the mental disorders and the physical disorders. We should be treating. I'm not saying anything revolutionary. Everyone is saying that, but I think we need to start actually doing that and stop talking about it and do something about it. So, if anything, there will be a role for this medication in this area. Whether they will be used to treat psychiatric disorders in their own right, I don't know. I can only hope so. I don't think that the medications, the GLP-1s we have today, are necessarily going to be the best candidates for doing that. I think we're still a little bit far away. Maybe we need medications of this kind that penetrate the blood-brain barrier more. Maybe we need medications of this kind that penetrate the blood-brain barrier less, so that we avoid potential side effects of this. We simply don't know yet, but in one way or another, I think the GLP-1s are going to play a role in neurodegenerative disorders. So, just to be clear, dementia, especially Alzheimer dementia, if anything, because of all the inflammatory mechanisms we have been talking about a lot. I would be surprised if addiction was not an avenue where this medication would play a role, and maybe for other psychiatric disorders like schizophrenia and depression as well. We will see.
So the future is bright. The future is bright, which is good.
We have to think that, right?
Exactly. We might as well be optimistic because that's what drives research and progress. Thank you for coming on to the show. This has been super fun, super educational. I learned a lot, and hopefully our listeners have learned a lot as well. So thank you.
Thanks to you. It's been a pleasure.
Awesome.